Hi everyone, welcome to CADIO's webinar series. Today we are so happy to be joined by Dr. Ellen Fitzsimmons-Craft. Dr. Ellen Fitzsimmons-Craft is an associate professor of psychiatry at Washington University School of Medicine and a licensed clinical psychologist. She has established programmatic lines of research centering on the use of technology for eating disorder prevention and treatment, eating disorder screening, and college mental health. Ultimately, Dr. Fitzsimmons-Craft's work aims to disseminate evidence-based interventions from research to practice, as well as extend treatments in ways that will reach the large number of people in need of care for mental health problems, but who are not receiving services. She is a fellow in the Academy for Eating Disorders and is a current recipient of a National Institute of Mental Health Career Development Award. Dr. Fitzsimmons-Craft is passionate about increasing access to scalable, evidence-based mental health services, collaborating with numerous industry partners, nonprofit organizations, and statewide groups in the U.S. in order to do so. So once again, welcome, Dr. Fitzsimmons-Craft.
Great. Thank you all for that super nice introduction, and really appreciate the opportunity to be here today and speak a little bit about the work that I and my team have been doing on optimizing a chatbot to facilitate mental health services use in individuals with eating disorders. So we'll go ahead and dive right in and just have a few commercial relationships to disclose, but none of which are directly related to the work at hand. Okay, so in terms of setting the stage, for those who may be, sorry about that, less familiar with the problem of eating disorders affect up to 10% of the population will suffer from clinically significant eating disorder symptoms at some point in their lives. Eating disorders are also associated with high medical and psychiatric comorbidity, poor quality of life, high mortality, and in fact, mortality from anorexia nervosa is the second highest of all mental disorders, surpassed only by opioid use disorders. So these are, contrary to some stereotypes out there, very serious mental illnesses. These are also the 12th leading cause of disability in young women in high-income nations. And we also know that eating disorders have completely skyrocketed in the pandemic. The prevalence of eating disorders is up, the severity of eating disorders is up, and providers are more overwhelmed than ever. And these problems have seemed to persist even as we get into this kind of, post-pandemic period. We also know that, unfortunately, there's a very wide treatment gap for eating disorders. And by that, I mean less than 20% of individuals with eating disorders ever receive treatment. And even when they do receive treatment, it's likely not evidence-based. There's also a paradox that exists such that although few individuals with an eating disorder receive treatment specifically for that eating disorder, these individuals are actually more likely to receive treatment and incur higher health services use costs than individuals who don't have an eating disorder. So it's not as though these individuals are getting no care, they just may be getting other types of care that are not specifically addressing their eating disorder. And these delays in treatment can result in prolonged illness, disease progression, poorer prognosis, greater likelihood of relapse. So, really a very significant problem that much of my work has been looking to address. And in particular, we've been looking at the issue of screening and identification as a really crucial first step in accessing care. Identifying or learning one's symptoms or something that in need of help is, again, really crucial first step. And this is especially critical in my mind, given that less than half of individuals with eating disorders recognize they have a problem. At the same time, which makes sense, self-recognition is associated with help seeking. And in one study, close to half of participants who recognized they had a problem with their eating had ever sought treatment, versus only 1 in 5 who didn't recognize a problem had sought help, which again makes perfect sense. But we have these issues currently in terms of screening and identification that don't allow for those opportunities for individuals to readily recognize that they may have issues in need of treatment. And in the case of eating disorders, a problem that's perhaps even worse than other mental health problems, there's just a lack of screening for these issues. In the case of colleges, one survey found that only about 22% of colleges offer year-round eating disorder screening opportunities, despite the increased prevalence of these disorders in that population. Even when screenings are offered, they often only reach a small number of students in the college setting. And we also don't have any eating disorder screening guidelines, any guidelines that may mandate or strongly recommend eating disorder screening. For example, just last year, the U.S. Preventive Services Task Force did an evidence review of eating disorders screening in adolescents and adults, and recommended that the evidence was not sufficient currently to yet recommend universal eating disorder screening, like we may do in the case of depression, which is universally recommended in postpartum women, for example. And so, it made sense given the lack of research in this area, but was of course also disappointing to those of us working in this area, and is something we're actively working to address. But all that is to say, we don't currently have widespread eating disorder screening happening. Providers also miss eating disorders. A majority of individuals who receive treatment for an eating disorder are first seen by a primary care physician, but one study found that over 90% of such frontline providers reported believing they'd missed eating disorder diagnoses, again, suggesting it's not as though individuals with eating disorders aren't presenting to the healthcare system, they're just not always being caught. And individuals from racial and ethnic minority backgrounds with eating disorders are significantly less likely than their white counterparts to be diagnosed with an eating disorder, or to even be asked by a doctor about eating disorder symptoms. And I think this is in part due to this misconception that eating disorders are rare problems that affect only, the stereotype is often described as skinny, white, affluent girls. But in fact, research has shown that eating disorders don't discriminate and really do affect individuals across all demographic groups. And so I think all these factors really together highlighted to me the importance of readily available eating disorder screening that provides individuals with tailored feedback on their symptoms and concrete suggestions for next steps. And so in terms of meeting this need, myself and colleagues worked with the National Eating Disorders Association to make evidence-based screening available on their website. And so our group had worked to establish a eating disorders screening tool that allowed us on the back end to sort individuals into probable eating disorder risk and diagnostic categories, an instrument that we refer to as the Stanford Washington University ED screen, or the SWEDE. And what we did around 2017 or so was we worked with NEDA to make this screening available on their website. Really quick and easy, only takes people about, less than about 5 minutes, maybe 8, to complete this screening, and then they get some tailored feedback. And so what we found is that this is really reaching people in need. It's completed by up to 200,000 respondents per year. And what we've also shown in our research is that if individuals are making it to the NEDA screening, the vast majority screen positive for an eating disorder, but most of those, about another 86%, have never been in treatment. And you can see in this map here with the green dots to the right, this is just a plot over the course of 1 year. All those, who were reporting having an eating or, screen positive for an eating disorder and not being in treatment. So you can see they're kind of all over the country and located everywhere. At the same time, only 3% of individuals reported currently being in treatment. So pretty dire situation. And you can see those folks represented by these incredibly sparse pink dots on the map right here. And so at the end of this screening, what happens is individuals are given some feedback. We don't claim that this is a replacement for a diagnostic interview with a licensed provider, but we do provide individuals some feedback that they may be at risk, and now may be a good time to start to explore some help opportunities. And so individuals, were given a variety of resources that they could contact through NEDA, free and low cost support offerings and directed to other resources. And what we found in our research was that only 16% of those who screened positive for an eating disorder and not in treatment initiated any type of care following screen completion. And this research was definitely limited by those who are willing to provide us follow-up data. And so this is certainly a gross overestimate. I'd venture to guess that of all the screen completers, probably less than 1% perhaps get treatment, after taking the screen. But this is the best data that we have. And again, is of course reliant on people willing to provide us this information. And so the thought was that we really need a novel solution to increase access to care. We thought that this novel solution needed to not only identify individuals with eating disorders, but to also help address prominent barriers that patients face in seeking and receiving timely care, such as, again, those stereotypes about eating disorders that may not only leave providers not feeling like individuals have a problem, but also lead to individuals themselves perhaps not believing they may have a problem. Issues of denial of illness severity. Eating disorders can be very egocentric. And so some people, may not feel that their problems are that severe, or may even feel like their problems are part of who they are and thus not really a problem. There can also be issues of limited motivation for care and a lack of knowledge about treatment. And at the same time, it's clear, given that data that we said, even when individuals were provided resources for learning about different care options through a national nonprofit, individuals weren't getting access to treatment. And so there was this issue of also needing to better connect individuals with resource. And so our thought was that a chatbot could offer one accessible solution to tackle patient barriers to seeking treatment and better connect individuals with resources. There's been some data to suggest that humans can respond psychologically to chatbots as if they were people and be very open and honest with chatbots. And some research conducted by our team and others has also shown that chatbots can be used to improve mental health symptoms like body image and to promote positive health-related behavior change. Other positives of a brief intervention like a chatbot includes that it could be interactive, perhaps encourage honest disclosure, especially for those who may have a lot of shame or feel a lot of stigma around these concerns and perhaps have never talked with a real person, anyone at all about these issues. They can also be used anytime, anywhere, so accessible, during hours when, human support is not available. And as I noted, maybe especially useful for those who've never spoken with anybody and have that high level of embarrassment or shame. And so what our team did was we were interested in specifically designing a chatbot, this brief digital intervention that could be used to increase services use for eating disorders. And so what we did was we developed a text-based chatbot that was in our research delivered via SMS or Facebook Messenger. And this was developed using a rule-based approach, including complex decision trees. So in the past, I'd say year, the world has entirely changed in terms of, ChatGPT and other generative AI tools coming on the scene. And this work was all done pre-ChatGPT. And given that we were wanting to really deliver here a very structured intervention, a rule-based approach made a lot of sense anyway. And so just wanting to kind of clarify that at this stage, this was this totally rule-based chatbot. And this chatbot included 4 theory-based components that we were interested in evaluating and that we thought could improve services seeking. So one being psychoeducation. So this was really based on that, mental health literacy model and our idea that, again, perhaps some individuals may not even realize that they have a problem that's in need of treatment. And so in this component of the chatbot, it busted common myths about eating disorders and also provided some tailored psychoeducation based on what the user reported struggling with and helping individuals to recognize the seriousness of their concerns. The second component was a motivational interviewing component. So we really tried to distill down the basic tenets of, like Miller and Rolnick's motivational interviewing approach, and built the chatbot to really highlight discrepancies between unhealthy thoughts or behaviors an individual is having and their healthy goals in order to further kind of motivate change. The next component that we built was a personalized services recommendation component. So instead of what I like to refer to as like the laundry list of things that individuals were historically provided at the end of the NEDA screen, and is really the typical approach taken at the end of any kind of online mental health screening, including those offered by other large nonprofits across the country for other problems, we really wanted to provide tailored help-seeking resources based on user preferences, and really like drill down into like one or two things that the individual may be interested in trying. And then finally, we were interested in this repeated administration or repeated check-in kind of component that would check in with users after the initial conversation, which, if you can believe it, is not really something that we typically do, after mental health screening. People take it and then that's kind of it. And they're, maybe again, given that laundry list. But instead, we really wanted to build into the system this repeated check-in to provide a reminder of treatment resources and also to address any barriers that individuals were facing in seeking out help. And so this was just our conceptual model in terms of what we thought each of these components kind of may target. Again, that psychoeducation, kind of trying to increase mental health literacy. Within that motivational interviewing component, trying to increase cognitive dissonance. Within the personalized recommendations component, it has been shown that tailored messages are, outperform more generic ones in affecting health behavior change. And so we thought that the personal relevance, as opposed to hearing one or two recommendations that feel most relevant to me and what I want or need in this moment, might prove to, generate some effectiveness in terms of increasing mental health services use. And then finally, we thought that those repeated check-ins could act as a reminder to really be an adherence mechanism, so to speak. And in general, reminders to increase adherence for health-related interventions have been shown to be pretty important. And this just gives you a quick snapshot of what each of these conversations may have looked like. Each of these first components took about 5 minutes to go through, perhaps less. So you can see in the psychoeducation component, the chatbot is asking somebody, can you tell me more about what's been going on for you? Maybe somebody describes that they've been really having a difficult time with purging or self-induced vomiting. Really scary because the last time I went to the dentist, I was told my purging has given me many cavities. And so, the chatbot tried to reinforce that, provide some empathy and also to provide some recognition on some of those effects that these eating disorder behaviors could have. And so this is just a sample of part of the conversation. I'll show you more about how the MI part worked in just a moment. But again, that really worked to, increase those discrepancies between healthy goals and unhealthy behaviors. The personalized recommendations component, asked individuals about the best fit for their needs at the time and what kind of support they were looking for. And then again, kind of drilled down to provide them just one or two types of recommendations. And of course we were, and this is another, larger issue that we can talk more about, but we're limited in terms of what's available that we were able to provide as recommendations at the time. And then finally, in that repeated check-in or repeated administration component, like I said, the chatbot really followed up with folks, so you can see one example here. I've been thinking about our conversation and I'm curious to hear, have you received the help you want for your eating or body image concerns since we last talked? And maybe in this instance, somebody said they had, and the chatbot would stop following up at that point. But if they hadn't, it could brainstorm kind of next steps. So here's a little, super brief video to give you a little bit more of a sense of the interactivity of the bot and how it worked. And so this is just a sample of part of the conversation from that motivational interviewing component. And so, here Alex, our chatbot, is asking somebody if they're willing to chat a little bit more about their screening feedback, referring to that feedback they'd gotten through NITA. Someone says yes. And, Alex says, I appreciate your willingness to discuss your concerns. What made you decide to use the screening tool? Somebody says, I've been struggling with how I feel about my body and what I eat. And so Alex, again, kind of provides some reinforcement. I'm glad you decided to take a closer look at some of these things that may be bothering you. What was your reaction to your screening feedback, saying that you may be struggling with disordered eating? And so the individual, kind of types in their response, how they feel. I felt sad, but I also wasn't too surprised. And Alex, again, kind of thanks them for sharing, helps to emphasize that the fact that they're here shows that maybe a part of you worries that something might be wrong. And then moving on to a little later part of the conversation in the MI component. Oops, and let me pause the one on the left. On the right, we can see that Alex is starting to ask about individuals' confidence to make change. If you decided to address your concerns, how confident would you be that you could do it? And this person says 1 on that 1 to 10 scale. So I'm not at all confident. So Alex is able to understand, sounds like you're uncertain about your ability to address this. Tell me more about it. Why did you pick that number? I just feel like I don't know where to start. And this is all very similar to how one might do this in like a therapeutic context too. And so Alex says, I know it can be tricky to think about what would make you more confident in your ability to make progress. And this person says, someone telling me what to do. And so the conversation kind of goes on, but again, sort of getting people thinking about their confidence and self-efficacy to make changes at this time. So that's just a super brief snapshot to give you a sense. But this was something that we really developed using a high level of user-centered design and usability testing. As I mentioned, this was a totally automated, it was a synchronous conversation, and it was initially drafted by myself, team members, expert clinicians and other partners in the field with a high level of kind of expertise and working with individuals with these concerns. And then we recruited people to engage with iterative versions of the bot. And so, we found individuals who are just like those that we would, recruit through the NITA screen. So adults who were screening positive for an eating disorder who weren't currently in treatment. And then we conducted usability testing over 4 iterative cycles. So again, showing people kind of progressively improved versions of the bot over time. And we collected standard information on usability throughout, and also did a semi-structured post-study interview. In terms of some of the themes that we heard across cycles, we were impressed by people feeling like this was really easy to use. They felt like it was super straightforward, it was easy to respond, and they didn't really have a lot negative to say in that regard of sort of being easy to use or not. Again, it came right to people's, text messages or through another chat platform like, sorry, but I'm having trouble with my mouse today, like Facebook Messenger. So they found it super easy to use. In terms of chatbot qualities, things that people liked were the supportive and motivational tone. They also liked that the responses were quick. The chatbot seemed impartial and engaging, and it also seemed rather realistic. At least some people felt that way. Other, less positive feedback included some comments about being automated or robotic, some of which, of course, is inherent in a chatbot. It's not intended to be a replacement for a human. Instances where it felt awkward or it was frustrating that its responses were somewhat limited. And in terms of the user experience, people liked that it felt comfortable, private, safe. And in terms of more negatives, other people sometimes might have felt that this wasn't super relevant to them, or maybe it wasn't motivating them. And so, just to give you a sense of some of the, more positive feedback that we got and why a tool like this could be so helpful for increasing connection with services. One quote was, "I like that you can be more honest with your feelings because you're not face to face with somebody." So here's somebody who's actually looking for, an anonymous sort of digital tool. They don't want to talk to someone yet, which is okay. We want to meet people where they're at. Someone else saying, "I felt really comfortable. It was like talking to a person, but in a more anonymous way." Another person saying it was kind of relaxed because, it's not judgmental. With something like this, everything and everybody's judgmental. I mean, the entire world out there is judgmental, particularly with social media and crap. So it was kind of nice to just be able to get it out. And then finally, some people thrive on having that one-on-one interaction, and some people would rather be able to look up things on their own and then just touch base with the chatbot. It lets you allow the dose in which you take it in instead of having a person push and push and push. And so I think this just kind of highlights these quotes, some of the general themes and the feedback that we got. Of course, not all the feedback was positive, and we wanted to hear what people didn't like as well. One person saying, "The one thing I didn't like is that it bottlenecked you," which I understand that it's a bot and it can't recognize all sentence completely. So sometimes it could not understand what I was talking about. And so that was kind of captured in those themes we talked about a minute ago. Of course, it was not endlessly personalized or able to recognize everything. Another person saying, "This chatbot really made me feel like this was not the thing that I should be using because it's directed towards people who have real problems versus like my just general like mental blah about this versus actually doing dangerous things." So I read this as someone who perhaps hadn't quite yet understood or appreciated the severity of their concerns, because they did screen positive for a rather serious eating disorder. But, clearly we didn't kind of successfully get them to appreciating the severity of their concerns, which of course, people are going to take their time and can't convince everyone of that. The next one saying, "All the resources offered were just like things that are real serious, and I don't think I'm that bad." So again, kind of somebody else, again, just feeling like this isn't meeting their needs. This is not what they need at the time. And then finally, I also think, some people would just need a referral to like a doctor, and how do you even find that? That was a little more difficult. And so there were other comments as well about just some of the challenges in finding care, of course, not all of which we could address within the bot, given the larger landscape of challenges in accessing mental health treatment. But in terms of, we did make refinements over time to the chatbot, addressing what we could within the confines of, this rule-based chatbot that only is able to refer people to things that are available out there. Again, totally recognize that is quite limited, but we did improve what we could. And what we found was that, over time, that the language, we were able to make it even more empathic, more supportive to better motivate users and sound less robotic or automated, at least to the extent that we could. But the chatbot was always, very forthcoming that this wasn't a human and it wasn't intended to replace humans. It's just another tool in the toolbox. And then we also added material and resources to cater to even more diverse eating disorder presentations and challenges, and try to make this meet the needs of as many people as we could. And what we found, by the end of that process was that the chatbot showed excellent usability, even prior to refinements. People didn't have technical challenges or difficulty navigating, and individuals, generally seemed to find the chatbot to be empathic, personable, and they felt that those qualities encouraged honesty and improved their confidence and willingness to take the next steps. If you're interested in learning more about this, we published a whole paper on the development and usability testing of this chatbot, first authored by one of my trainees, Jillian Shaw. You can find that in a special issue of Eating Disorders on Screening for Eating Disorders. And there was also a nice, even quicker summary that was written up by NIMH in a research highlight. And so you can check that out if you're interested to learn more. So really the next step after developing, this, using all this feedback, was we really wanted to optimize the chatbot. We wanted to figure out which of these 4 components actually worked and made a difference. And this was because, even though this could be perceived as a very brief digital intervention, again, even if you got all those 3 main components plus these, check-ins over time, that still would be like a 15 or so minute conversation. And many people, the reality is, won't engage for that long. And so we thought that this was really important to figure out, how to make this kind of like the leanest and meanest bot, so to speak. And so the aim of this study that I'll get into talking about now was to conduct a randomized optimization trial with adults who'd completed eating disorder screening on the NIDA website and who did screen positive for a clinical or subclinical eating disorder but weren't in treatment. And the main outcome we were interested in was the effect of those chatbot components on mental health services use. But secondarily, we were also really interested in how helpful people found the tool. Of course, you want to make a tool that people actually perceive to be useful to them. And then another secondary outcome of interest, given that we know not everybody's going to seek help, but that doesn't mean that it might not have made a difference in one way or another, was to look at attitudes towards changing eating, shape, or weight concerns. So to see if we made kind of a dent in those concerns. And so what we did was during some periods of time in 2021, we recruited individuals through that NIDA screen, and participants were randomized using a 2 to the 4 full factorial design to receive up to the 4 chatbot components. So each of those components, psychoed, motivational interviewing, the personalized services recommendations, and those repeated check-ins were on or off, such that I know this group knows well kind of what that design looked like. So I won't belabor that today. In terms of assessments, participants were assessed at baseline, and then 2 weeks later, 6 weeks later, and 14 weeks later. 2 weeks was partially because if they got randomly assigned to that repeated check-in component, the check-ins occurred about up to 3 times over the course of 2 weeks. So the first one, 3 days later, where we, asked, hey, did you get that help that we talked about? And if not, it worked to address barriers and remind them of resources available. And then it would follow up to 2 more times if people still reported not receiving help. In terms of our primary outcome, this was a pretty liberal definition of mental health services use. Have you tried or used any type of mental health help for your concerns related to your eating, shape, or weight in the past, whatever? And so we asked about the period of time that we were assessing, since baseline, essentially. And we were interested in kind of incorporating trying, again, given the difficulties of accessing mental health care. And we do get more even fine-grained information, but we thought this was an important first level outcome. Helpfulness was assessed after that first main conversation. And we just asked people how helpful that was, this conversation. And then change attitudes were asked by looking at how important it was for individuals to change their eating, shape, or weight concerns, and then how ready they were, which were each assessed on a 1 to 7 scale and then summed. In terms of our analytic strategy, our analyses focused on main and interactive effects of the chatbot components, and data on that primary outcome was analyzed using discrete time survival analysis. And we were essentially looking at the hazard odds of services use among participants who had not already sought treatment at each time point. The data on chatbot helpfulness was analyzed using linear regression. We only analyzed this one time, measured this one time immediately after the chatbot conversation. And so we didn't expect this to differ as a function of those repeated check-ins because individuals didn't actually get those yet when they were responding to this item. And then the data on change attitudes were analyzed using linear mixed effects modeling, and then missing data was handled using multiple implementation. Here's just a brief study flow diagram. As I mentioned, the NIDA screen reaches a lot of people. And so during the period of time that the study was open, we had the luxury of being able to actually see how many people took the screen, which I'll put my plug in. I think it's really important for us to look at reach of interventions and focus on this. And so, we've done some more work kind of looking at that. But the NIDA screen during the time period reached over 12,000 people. People were excluded for not meeting study entry criteria. So we showed the opportunity to about 6,700 people, and then eventually had a final randomized sample of 205. And so our participants on average were 33 years old, but we had a wide age range, 18 to 73. In terms of gender, 90% were women, which does somewhat match the presentation of individuals who at least present for care for eating disorders. But, eating disorders in men and individuals of other genders are increasingly being recognized. But this does match, who kind of takes the NIDA screen. In terms of sexual orientation, this was about 68% heterosexual, race, about 80% white, 8% Hispanic. You can see partnership status there, wide range of household income, and then also some variety in terms of that rural-urban classification. And all of these data, matched who presents to the NIDA screen fairly well. And you can see individuals kind of plotted on this map, again, kind of showing the reach that we had reaching people across the US. In terms of eating disorder diagnoses, this was based on that SWEDE instrument we talked about earlier. A smaller percentage of individuals screening positive for AN, which matches known prevalence, as well as what we usually see on the NIDA screen, and then more individuals kind of screening positive for bulimia nervosa, binge eating disorder, subthreshold variance, or unspecified feeding or eating disorder. But individuals' scores on the eating disorder examination questionnaire, which is like the gold standard self-report instrument in our field, were right at a 4, which is right at the clinical cutoff, so suggesting the high severity of the sample. They also had, mild depression, you can see indicated by those PHQ-9 scores, high endorsement of suicidal ideation, and also mild anxiety on average. And I think really important to note in terms of kind of putting these findings in context was that people had very high baseline change attitudes, which, again, we reviewed the study flow diagram. We saw all the drop off there was until people kind of actually said that they wanted to participate, which makes sense that we then recruited a sample who was highly motivated to change. This was really presented as a study if individuals were interested in engaging with a chatbot or a digital tool that might help them access services. And so, we did have this very highly motivated sample to begin with. In terms of some other just things that I think are interesting is just the baseline treatment history and barriers. I'll go through this quickly for the sake of time, but, again, very few people had ever gotten help, only about 37%. And you can see some of the barriers they've endorsed in the past that are really in line with some of the things we were working to address with this chatbot, things like feeling shame or embarrassment, not knowing where to go to find help, believing they should be able to help themselves, believing the problem isn't serious enough to warrant treatment's too expensive, I'm not aware. So again, all types of things that we were really trying to address in one way or another via the bot. In terms of our follow-up completion, overall completion of at least one follow-up was about 83%. So we were really pleasantly surprised that 92% of our participants started the main chatbot conversation. And of those, 81% completed it, which lasted about 5 to 15 minutes, depending on the number of components the individuals was randomly assigned to. So we were pretty pleasantly surprised by that. And then moving on now to our primary outcome results. So overall, what we found was that 40% of participants reported services use by 2 weeks, 49% by 6 weeks, and 58% by 14 weeks. And across the entire sample, participants were most likely to initiate services in the first 2 weeks following the chatbot intervention. And then in terms of those chatbot components, what we found was a significant effect of that repeated administration or repeated check-in component. And so receiving that component was associated with higher odds of services use. As you can see, those who received it on, odds of services use or probability was, above 60% versus those off, it was, a little bit above 50%. For personalized recommendations, this was associated with higher odds of services use, but the difference was not significant. You can see, though, by 14 weeks, as indicated on this figure here, we're seeing a difference that's approaching 10%, but this did not emerge as significant. And the effects for motivational interviewing and psychoeducation were not significant. And there were no interactions among components. So really, this analysis only provided kind of strong support for repeated administration as a chatbot component. In terms of the type of treatment, just because I think this is interesting that people endorsed using at any point during the follow-up, you can see the spread of what people reported, makes sense. Smaller reports of things that are more intensive services like inpatient psychiatric hospitalizations or partial hospitalization, with more reports of things like telehealth, outpatient therapy, online self-help, online guided self-help. And I think it really interesting, and again, speaks to the problem of lack of access to care, that about 25% of respondents of those who reported any services use reported using technology-based services not focused on EDs at all. For example, Calm, a widely available, mindfulness meditation app, or that could actually make eating disorders worse. So for example, something like Noom for weight loss. Of course, none of these were things that were recommended to people after the screen, but I just think it's interesting that in this environment, that's what they're finding, because that's what's, perhaps readily available and being marketed to them so heavily. I don't know about you all, and probably based on my Google history, I get a lot of Noom ads and flyers in my mail. In terms of helpfulness, so we found significant differences. Again, we didn't expect any significant differences for repeated administration because people hadn't even gotten this component. And in fact, no significant differences there. There were also no differences on helpfulness for psychoed, but we did find significant differences for motivational interviewing and those personalized recommendations. So participants who received MI and PR found the chatbot more helpful immediately after the conversation than those who did not receive the components. In terms of change attitudes, the sample average effective time was negative and significant, meaning that change attitudes actually declined over time on average, which perhaps again makes sense if we think about who this sample is. These are individuals who at the time had sought out themselves the NEDA screen and might have been at the height of some level of motivation or attitudes towards change, and then these kind of declined over time. But we did find significant interactions between MI and time and between RA and time, which I'll talk about now. So participants receiving that MI component experienced a small to medium and significant decline over time in change attitudes, whereas participants not receiving that actually experienced a smaller but still significant decline over time. So this suggested that actually MI was associated with a larger decline over time in participants' change attitudes, which was very surprising originally, given that, as sort of one of the developers of the chatbot, we probably thought that was like our best, most like robust psychological intervention, so to speak. We've really like replicated something that we might do in a psychological intervention, but we're finding, based on this change attitude finding, that this was actually associated with a larger decline over time in participants' change attitudes. Participants receiving those repeated check-ins experienced a small but significant decline over time, but participants not receiving this experienced a small to medium decline over time. So this means that essentially that repeated administration component was associated with a weaker decline over time in participants' change attitudes. There was one significant higher order interaction between time, MI, psychoed, and personalized recommendations. And this is a plot of the simple slopes of that. And what you can see here with personalized recommendations was this effect was actually non-significant and very weakly positive in terms of the effect on change attitudes, versus for kind of all other combinations between these three components, the effect of time was either, weakly and non-significantly negative, or even significantly negative. So overall, the effects of MI, psychoed, and personalized recs on change attitudes depended on each other, and it seemed that delivering personalized recommendations without motivational interviewing or psychoed was actually associated with the most favorable time trend of change attitudes. So kind of moving on to like wrapping all this up before we open it up for questions, was we found that overall about 58% of our sample reported services use within 3 months following screening. This was very high compared to that 16% that we observed in our prior work, with the caveats again that this is a selected, motivated sample. But we were still encouraged by that high rate of services seeking. Now, then if we think about our pattern of findings across these outcomes, it's where it gets a little tricky to consider, well, what components do I want to retain in my optimized bot? So first, if we think about our effects on services use, the analysis only really provided support for repeated administration. That was the only significant finding for that primary outcome. And we also found that for change attitudes, repeated administration was associated with a weaker decline over time. And so I think on the whole, that made me think, well, looks like overall these things seem to make a difference. And so those repeated check-ins seem like they're pretty helpful in terms of increasing services use. And again, like staving off those declines in change attitudes, which makes sense. Again, you have a bot following up with you, providing reminders, helping you address barriers. For personalized recommendations, as we talked about, this was trending in the right direction for services use, but was not significant. But we also found that people who got personalized recommendations did find the chatbot more helpful. And then there was that interesting, three-way interaction that we talked about, whereby delivering personalized recommendations without MI or psychoed was actually associated with the most favorable time trend and change attitudes. So we're kind of left with, what do we make of this? What do we do with personalized recommendations? Then thinking about motivational interviewing, well, people found that helpful. As we talked about, the bot was perceived to be more helpful if people got that component versus not. And as I mentioned, from sort of a developer perspective, that made sense to me because it was an engaging component and it was perhaps the most like psychological. But we found that it was also associated with a larger decline over time in participants' change attitudes. I could, get into this further, but, I think this finding is important in the context of starting out with that highly motivated sample. And after finding this surprising finding, I did find some other literature that suggests that motivational interviewing may actually not be that useful and perhaps even unhelpful if people are already pretty motivated to begin with. So that may be what is explaining our finding here, but still interesting. And then on the whole, psychoed is not really emerging based on these findings as really doing anything, which it was not that also terribly surprising, even if on the one hand, we felt it might be important to help bust some of those myths about eating disorders and provide some education on the negative effects. It wasn't emerging as a big, kind of driver here, which is, again, kind of consistent with some other literature. So in terms of the next step, as you all know well, the current approach for optimization decision-making is this component screening approach, but this can be challenging to apply. And what if there are multiple outcomes that you're interested in, such in a trial like this one that we did, where, definitely getting help is kind of like the end all be all, but we want to recognize other outcomes that might be on the pathway towards help seeking, especially for those who, may not be ready yet to seek help or maybe can't seek help for whatever reason. We still felt it was important to consider those effects on helpfulness and change attitudes. And so this is where Jillian Strayhorn has been gracious to lend some of her expertise, helping us to think about how we might use her new approach to decision making. She has this super paper published earlier this year in Psychological Methods, but using this approach that would allow us to better consider multiple outcomes and weighting those outcomes differently and looking at how that might affect our decision-making process, as opposed to just looking at one outcome or doing what we're doing here today, kind of trying in your mind to piece together how to understand these multiple pieces of information. Other next steps I'm really interested in are determining relevant baseline moderators. So for example, certain demographic characteristics or baseline motivation. As we talked about, the sample was really highly motivated on average, but I'm certain there were people that were less motivated as well, or that we could find in the future. And so, for what is the best optimized chatbot package for those individuals, which again, I think is a really important question, given that, I'm really interested in disseminating interventions at public health scale, reaching people through, for example, the NIDA screen, up to 200,000 people a year. So we really need our interventions to be as lean as and really only include those most effective components. And so once we can figure out this decision-making issue, I'm excited to do an RCT of an optimized chatbot versus sort of the usual approach that's taken at the end of mental health screening. Of course, another exciting next direction would be to pair the chatbot with an actual digital intervention to further reduce barriers to access, and then also to integrate some more AI features. We started all this work well before ChatGPT and the onset of generative AI, and we felt very strongly that a rule-based approach was the way to go, and that may still be the way to go given the structured intervention we're trying to deliver. But certainly in this day and age, it'll be worthwhile to think about how to very thoughtfully integrate AI features that could make the bot even more personalized, but with tight guardrails. So I know I've gone over, but I really appreciate the attention. My contact information is up there. I'm happy to answer questions at any time. I'm very appreciative of all my collaborators in this work, which was funded by a National Institute of Mental Health K Award, as well as all the members of my team, without whom this work would certainly not be possible. So thank you all so much.
Thank you so much, Ellen. I want to make sure that we get to any questions if people have them. So feel free to put one in the chat or raise your hand if you have a question. And of course, in this room, you can physically raise your hand if you have a question. I actually have a question that I was thinking about as you were speaking. I was thinking about that finding with motivation and seeing it decrease in some people, and what you were pointing out about your highly motivated sample. And I'm curious, have you thought about the relationship between that sort of motivation and the sort of continued engagement in treatment that might be necessary as somebody not just acquires a service, but continues to work with that service? Do you think that those outcomes are related to one another in that sense? And does that affect how you think about that finding at all?
Right. So just to summarize, so how motivation might look if you get into treatment and how, right, exactly. And this is for that reason, I think, a really challenging outcome. We also did do some assessment of how motivated people were for help seeking, and have done some analyses looking at effect on that in the subsample who never received treatment. But even there, if I'm recalling correctly, we still weren't finding that, motivation was really popping out, which again, may have something to do with this highly motivated sample. And so if I were to do this trial again, complicated, but I'd probably think about another way to recruit. But it's still hard because, again, of course, people in our research studies have some level of motivation to come into them, right? So it's hard for you to capture that full sample of people who may need some help.
Yep. Yes. So a question in the chat for you. The public perception of chatbots has seemed negative after what happened with the NIDA helpline employees. Wondering if you feel that may pose a barrier towards further research on this.
Yeah, I mean, thanks for asking. And I know that's a big issue that I could do a whole talk on and you know, could talk a lot about. But for those who aren't familiar, you know, there was some controversy not related to this bot, but over the summer when, you know, NIDA made the decision to close their helpline. And at the same time, there was kind of a misperception that a different chatbot that our team had worked on that was actually delivering an eating disorder preventive intervention was meant to be a replacement for that helpline, which again, they're kind of offering two completely different services, you know, sort of one being an information and referral helpline versus another offering a preventive intervention. And so the chatbot kind of got swirled up in a couple of levels of controversy that I don't have time to get into. But, you know, I think certainly that situation, it hit on a lot of important issues at a time when there's understandably a lot of questions around chatbots and AI and concern about these things, you know, kind of coming for jobs, for example. Clearly, that's absolutely not my intention. And I'm really just working to make tools to help individuals get connected to care and to serve functions that I don't think are available to people in any way. And so, you know, a good question. I don't know that I can fully get into the answer today, but I certainly think there's still potential and, you know, there's important work that needs to be done in this space. And I hope we won't throw, you know, the baby out with the bathwater. Certainly we have to be really careful in implementation of tools. But I don't think that means that, you know, we should write these tools off. You know, there's not really a good alternative. Again, there's nothing really currently serving the function of the bot we talked about today to try to facilitate that connection from screening to care. And so, you know, I think it's still an important area of investigation.
Great. All right. Let's see. It's about time anyway. Okay. Well, we'll close there. And once again, thank you everybody for your time and attention today. And thanks so much to Dr. Fitzsimmons-Craft for a really, really interesting presentation.
Fantastic. Thank you so much. Thank you for having me. I really, really appreciate it.
All right.